Hi, Dr. Shapiro here, and we're going to talk about fixation for foot and ankle trauma. The main objectives here are really to talk about the specific kinds of fixation and give you a little bit more detail about each of the types that you'll come across. Remember that all of this is based off of four primary AO principles. These principles are first anatomic reduction, so putting the anatomy back to its proper form to allow for better function later, fixating that form with good stable fixation, preserving the blood supply during the surgery to prevent destruction of bone, and all of these things should allow for early and safe mobilization. Remember that mobilizing a joint or an area that you fix does not mean that the patient can bear weight immediately afterwards. Okay, so the first thing that happens when you're going to put a screw or most types of fixation in is that you need to drill a hole. So surgical drill bits are the first thing that you need to know about. There are different lengths and sizes. These all depend very much on the specific equipment you're using. If you look at these, you have a helix shape or a twist to it. A slow helix is kind of a longer type of curve, and this is easy to clear debris with a longer one because it's pushing the debris out further, while a quick helix with a more rapid turn is harder to clear. The other thing I want to point out is the tip of the drill bit is very important. And the one thing to make clear here is the flute. So a flute is just an area, it's like a divot in the end, and that flute is what starts to clear the debris as you're drilling. You can also have a flute on screws, and that flute is what creates a self-drilling type of screw. Okay, so remember surgical drill bits. Now, when you use them, you can create complications. And the main complication we have to worry about is thermal necrosis. So, of course, as the drill spins, it creates heat, and you want to avoid that as much as possible. So excessive heat will lead to resorption of bone, and that could lead to loosening of your implant, backing out, or even sometimes infection. So in order to limit the amount of heat, there are a few different things you can use. So first of all, a sharp drill bit as opposed to a dull one will go through the bone faster and easier and create less heat. You should always drill at full speed because faster will again go through bone a lot quicker. You can use irrigation, so it's common to drip a little bit of fluid on the area to help keep the hole cool. And then, of course, to avoid long drilling time. So you should go through that bone relatively quickly and not have to spend a lot of time. And moving on to Kirschner or K-wires, these are things that are commonly used, especially for temporary fixation. So this is just simply a long wire that comes in some different sizes and different lengths. And they have different tips on them, as you can see in this picture. The A picture is a trocar, which is essentially just a sort of like a pencil point, a diamond tip, which is sort of flatter on two sides, and then the medine, which is a much less common type of K-wire. So the other two are kind of more common, and the trocar is our single most common. Another version of a Kirschner wire is a Steinmann pin, which is essentially the same thing as a Kirschner wire, except they come generally much larger and in many cases longer. You generally do not use these as long-term fixation unless for certain circumstances, which you learn over time. These are only as stable as the original osteotomy. So for example, if you created a flat osteotomy that was unstable, then using a K-wire would not provide much more stability because it doesn't compress or hold things. And you want to try to make sure whenever possible that that K-wire goes in 90 degrees to the fracture and that you'd use a second wire. Cerclage wire is the next sort of form of fixation. This is simply just a thin wire that you can wrap around different parts of bone, as you can see in the picture. It doesn't manipulate, you don't manipulate the wire too much when you use this because it's easy to bend and break this. Now, cerclage wires and other fixation are oftentimes used with what's called a tension band principle. And the idea of this is that you have a tension side, which is pulling the bone apart, as you can see on the left image, and a compression side, which is on the right side of this, the image on the left side, the more right side of that. So that is a compression or pushing together. And the compression side is more stable, while the tension side will tend to pull apart. So if we were to put something on that tension side, it would create, it would move the tension from pulling away to pulling together, which would provide stable fixation. So this tension band technique can oftentimes be performed with a screw or sometimes a plate. It could be used with external fixation, and even K-wires and cerclage wire can also be used as a tension band principle. And this is typically done for small fragments and maybe areas that are harder to use, harder to access. Transverse fractures like avulsion fractures are oftentimes amenable to tension banding. So here's an example of a tension band wire used to fixate a medial malleolar fracture. There are two K-wires that are put in, and then those K-wires are bent, and then you can see that the cerclage wire is placed in sort of a figure of 8 fashion, and in this case, it's drilled through the bone, like a little tunnel is drilled through the bone, and the wire is put through that. That creates a tension band effect on the medial side of that fracture, pulling that tension side into a compression side. Another way to do this is to put a screw proximal to the fracture that you can then wrap the wire around, which is the image on the right side. Using a screw like this is oftentimes called a hangman's screw. So if somebody mentioned about using a hangman screw, this is kind of what it would look like. So instead of having to drill a hole through the tibia, you're just putting a screw in it, and then you're literally wrapping the wire around the screw, and then you tighten the screw in, and that actually even compresses the wire a bit more, creating a nice stable fixation. Okay, moving on to screws now. We're going to talk a little bit about screw anatomy, because the anatomy of a screw is incredibly important to how it functions. So obviously you have the screw is tube shaped, and you have that wide head. So this image is a screw with a head. It is also possible to have screws that are headless. So on the head, you can see the land, and the land is the bottom part of the head of the screw, and that land is going to push against the proximal part of the bone to help compress the bone together. Okay, then you have what's called the run out, which is the end of the shaft just before it becomes the threads. And this is the weakest part of the screw that is easiest to break. Then as we move down the screw, sort of to the right, we have the distance between the threads, which is called the pitch. And then towards the end here, you can see where it says core diameter. So the core is the inside part of the tube that doesn't include the threads. So that thickness that is not including the threads is the core diameter. And then if you were to include the threads, that's the thread diameter. So those are the primary parts of the screw. And of course, you can have the tip of the screw will vary based on its construction. There are two primary kinds of screws. There are cortical and cancellous. Remember, cortical bone is that hard bone on the outside, and cancellous is the spongy bone on the inside. And cortical threads tend to be narrower, or the thread pitch is closer together to allow more bone to grab. While a cancellous, the threads are wider apart to allow those threads to grab into bone that are spaced a little bit further apart. The threads themselves can also be constructed like a V, as you can see on that bottom image, or a buttress thread, and obviously those will grab the bone in different ways. Previously, it was common to have to tap or create the threads in the bone before you put a screw in. And in some cases, this still exists now, but it is increasingly common to have screws that are self-tapping. So they create their own threads as they go into the bone. Self-tapping screws typically have a lower pull-out strength because, as you can see in the picture, the self-tapping screw doesn't engage as much of the bone as the one on the left, which is a pre-tapped one. Now, as we look at this, how well a screw stays in the bone is its holding power. And obviously a larger diameter screw is going to stay in bone better because it's going to be contacting more bone, creating more friction and making a stronger connection. And as we mentioned, self-tapping screws stay in better because they contact more of the bone, allowing it to hold a little bit more tightly. Now, screws are going to be used in order to compress bone together. And this is a very important concept that you will have to know well in order to properly use fixation. And the lag technique, or using a screw to pull the bone together, is really important. So what we want to do is generally place the screw perpendicular to a fracture, and that will create the best tight fixation that you can. But what you want to do is have the threads only engage the far side of the cortex of bone. If you were to have it engage the proximal side, then it would basically hold the bone wherever it is. That is actually called a transfixion technique, and that is used in certain cases. For example, putting a screw into the syndesmosis of the ankle joint is one case, and some people will use this in addition in things like Liz Frank fractures. So after you reduce the second metatarsal and put it back onto the intermediate cuneiform, and you want to hold it just in the right spot, but not squeeze things together, you would then drill in such a way and put a screw in so that it just holds it there. And that would be putting it in as a transfixion screw. So what you would do to create a lag technique is to first under drill the hole. So whatever you're going to drill, it's going to go all the way, and then under drill is going to be narrower than the thread pitch. The thread diameter. So it's basically the core diameter of a screw. Okay, then you'll countersink in order to allow the land of the head to contact the bone. You then will overdrill the near side, and that overdrill is going to be wider than the thread diameter. So now the bone is only being pulled by the distal cortex. Okay, then you measure, you tap if the screw is not self-tapping, and then you put the screw in. And when you do that, you're going to be grabbing the distal side, pulling it towards the head, towards the proximal side. So the picture that we have here shows lag technique, but the one on the left is what I just described, and that is called lag by technique. While if you look at the other thread, the other screw on the right side of that image, that there are no threads on the proximal side. So the screw is designed to create a lag technique just by the nature of the screw. And that is where we are lagging by design. Okay, so we can also create a screw that has a core or a hole in the middle, and so that would allow you to put a wire, like a little guide. It lets you hold the fracture, and then you can put the screw in over that. And these are what are called cannulated screws. They have a hole, And these are usually self-drilling and self-tapping. The screw goes over the wire that you place and then take an x-ray to make sure it's in the right spot. So in situations where you can't see the fracture particularly well, then you might use a cannulated screw. Okay, our next sort of fixation method are staples. And you can see in this talonavicular fusion on the left, there are two staples, and staples come in different different types of constructions. The old-fashioned ones were just like a staple that you might have used in a piece of paper, but more commonly now, the staples are made so that there are two sort of holes that the legs of the staple go into, and then the central part of the staple, which is the bridge, is made to be spread apart. And as you spread it apart, you're going to bring the arms of the staple closer together, which is going to cause compression. And then in the image on the right, these staples are made out of something called nitinol. And when you warm up nitinol and put it into the body, then it causes compression. So the staple actually tightens itself once it becomes warm. So these are kind of the two most common ways that we might use staples. Now, one of the problems with staples, as you might imagine, is that the compression might be greater on the proximal side near where the bridge is, but as you go further out towards the tip of the arms, then you're not going to get as much compression. So you might not get even compression across the joint like you might with a screw or some other fixation method. Our next fixation method is an intramedullary nail. And these are really not terribly commonly used in the foot and ankle. We tend to use them for things like tibio-talo-calcaneal arthrodesis, which is obviously fusion of the subtalar joint and the ankle joint together. That is sometimes done, and that's what you can see in this picture here. An intramedullary nail is basically a large hole is drilled, and then the nail goes into the bone, and it basically compresses against the cortex of the bone to hold it together. And then, as you can see, in this picture there are 4 screws that are holding that nail where it is so that it doesn't move. And as you have put the nail in, it compresses everything together. The other place that intramedullary nails tend to be used is Charcot foot reconstruction, and we have smaller versions of these that can be put into the foot when you're doing reconstruction. Now, obviously, you have removed the cartilage, you've established the appropriate anatomic position, and then you put your nail in as your fixation, as opposed to putting in screws or plates. Moving on to plates now, we have two kind of primary types of plates, but as you can see here, this is what we're showing here is a compression plate. So a plate is just a piece of metal with a bunch of holes in it, and then you put a number of screws in it. And you can use the plate to create compression across the fracture. And the way you do that is to do what's called eccentric drilling. So as you can see in the image on the right, when you put a screw in on the hole that is further away from the fracture, so the screw will then slide downwards into the middle of that hole, and as it does it, it will cause compression because it's literally moving the plate. Some plates are manufactured specifically for this, where the holes are oval shaped, and you put the drill into the part of that oval that is further away from the fracture. And then when you drill it, and then the head of the screw hits the plate, it then slides into the middle. And we can see that in those 2 little circles on the image on the left, towards the bottom side of that image. The left side of that is looking straight down as if we're looking at the hole. And we put the screw in on the outside. And then as the screw goes in, it enters into the middle of the screw hole, and that creates some compression. There are some general rules for plates. So usually we want to use usually 2 screws minimum on each side of the fracture or the fusion site. If you want to have greater stability, you would then increase the number of screws on each side. The 2 screws that are closest to the fracture or the fusion site are going to bear the majority of the force. So you want to make sure that those are your most stable. An example of that would be to make sure that the screws go all the way across on both cortices of the bone to hold the plate as strongly as you can. Longer plates are distributing stress and pressures across a larger area of bone, so those create less stress. And the same thing is true with more screws. So the more you grab bone, the more you're holding things, the less stress you have. Now these plates may or may not actually compress anything. They may just be holding bone where it needs to be. And if that's the case, then you may need to put a screw into your fusion or your fracture in order to create the compression. So as I mentioned way earlier, you can use plates to create a tension band principle. So as you can see in this image, the tension side is the more lateral side or the left side of the left image. And the forces want to pull the bone away while the compression side is on the slightly more medial side of that fibula. If we put a plate on this after we have reduced the fracture, you can see that the plate is preventing the tension from pulling the bone apart, and that is holding it. So this plate is actually doing a tension band principle. Now it's important to learn, especially in ankle fractures, that plates have different purposes. So the same plate might be used to do different things. The first one is neutralization. When you neutralize forces, then you're preventing those forces from pulling apart your prior fixation. So in the image on the left, you can see that there is a screw outside the plate going through the fracture of the fibula, and then there's a plate sitting on top of it. If you just put a screw in by itself, it would not be strong enough to prevent all the twisting and pulling on the fibula. So you put a plate on it, and that prevents all those excessive forces from pulling, and that allows the fracture to heal. The other version of this is a buttress or an anti-glide plate. These are basically the same thing. They're oftentimes described as if they're two different things, but they're really the same thing. So you can imagine if you buttress something, you're preventing things from sliding or moving apart. So in this image, you can see in this femur, the fracture will want to move proximally. And if you put a plate on that proximal side, it's preventing the fractured piece from moving proximally. So that is buttressing it. And at the same time, that's also what's called an anti-glide. The bone is not gliding away from the spot where it's supposed to be. This is commonly done in fibular fractures as well, where if you put the plate on the posterior side of a fibular fracture that wants to slide proximally, if it did not have fixation, then the plate is functioning as an anti-glide, which is commonly commonly referred to on the fibula as an anti-glide and as a buttress when you're talking about the tibia or some other bone. In reality, these two things are doing exactly the same thing. So as I mentioned before about compression plates, you can kind of see a compression plates being used here. These are placed directly against the bone. They allow for anatomic alignment, and these are very rigidly fixating, which allow primary bone healing. So remember, primary bone healing is where you have no motion, and you have the bone, instead of forming cartilage in between, it just forms bone. That's your primary bone healing. And this allows, because it's so stable, it allows for earlier function of the patient. Now, all plates, including compression plates, can have complications. So you can imagine that in order to put a plate on, you may need to dissect a larger amount of tissue in order to fit the plate on. So that could create necrosis. Also, if you eliminate too much of the arterial supply, you're violating one of those AO principles, or the plate itself could be compressing the vasculature to the periosteum, which can also cause necrosis of bone. The other thing is that plates, because they function to shield forces, to prevent forces from going through the bone, then the bone itself may become osteopenic, and you'll get atrophy of the bone, which weakens it, and this is called stress shielding. So the plate has stress shielded the bone, which will weaken it, and in some cases that might require removal of the bone to allow normal forces to go through the bone and allow it to become strong. Plates can also be constructed in a form that allows them to be a little stronger, and so this is what's called a locking plate. And basically, the plate has its hole where the screw goes in, but the hole of the plate is threaded, and so is the head of the screw. So when the screw goes into that, it's going to thread into the plate as opposed to sitting on top of the plate and just pushing up against it. This is considered a more stable fixation. In some cases, it can be a little bit more flexible. This, when used by itself without any compression, will allow for secondary ossification or endochondral ossification. And this is a very strong type of fixation that is, again, oftentimes used in osteopenic bone and in other cases as well to allow a more rapid range of motion. So this picture just sort of shows how a locking plate works, whereas you can see a compression plate on the left side, and the screw itself is just sliding into the hole, pushing against the plate, and then the plate pushes against the bone. Whereas with a locking plate, the plate sits on the bone, the screw head is threaded into the plate, and it becomes as if it's one solid unit, and that creates a much stronger plate.